Thank you, Susan, again for inviting me. And Susan is one of our great organizers. I don't know if she told you, but she's retiring soon. I don't know exactly when her last day will be with us, but it'll be a loss for all of us. If we have time after, I'll show you my family. Ben, my son Ben is going to be 2, so he's and he's already terrible. And the main reason my productivity has fallen the last year. That's another story. How many of you attended my talk last year in October? 1, 2, okay, good. There'll be a lot of repetition. It's a talk on the same topic. I've modified some of the slides, but not all of them. And what I've done that's, I think, most interesting is I've actually changed the case that I'm going to describe. I'm going to start with the case first. This is a case of a patient that I saw here in clinic in February with our fellow Aaron Ritter. So it's technically Dr. Ritter's patient, but we're following this patient to the best of our ability. And I think it's a patient that illustrates well the disease and its consequences on both the patient and the family. So I'd like to start with that, and then we'll talk a little bit more about what we're going to do after. Do I have time here somewhere? 12:03. Okay. So, and I made the case a bit like I did the last time. I made the case with the same kind of labels that we use in our clinic. So when we see patients, we write ID and chief complaint and HPI and social history and family history. So you'll see a lot of these technical things that we use when we describe cases to other physicians and when we present them at conferences. So the ID of this patient, she's a 54-year-old, 54, in February of this year, year-old right-handed woman. She presented to our clinic in February of 2015 of this year. In fact, she didn't present herself. She was brought in by her mother. Now, this is unusual in a dementia clinic for patients to be brought in by their parents, but it does occur. The mother says, you know, we need to get to the bottom of this. There's something going on. The mother describes memory loss and behavioral changes. The patient, when we ask her why we're seeing her today, she says, well, I don't know. My mother brought me. She wanted me to be seen. Let me give you a little bit more history about this patient. So this is her social history. She completed high school and 3 years of college. It's not sure what she studied in college or why she stopped after 3 years, but that's higher than average education. She had a number of jobs, and gradually her jobs were of increasing responsibility. In fact, 5 years before she saw us, she was working at Arizona Charlie's. She'd started at Arizona Charlie's many years before and had worked her way up the ladder. She was a floor manager, so she was responsible for managing between 80 and 90 employees on a daily basis. So this is a very big job. It requires a lot of social skills, a lot of organizational skills, and certainly somebody that's bright and hardworking. More on her social history. She was married for many years. Her husband had been previously married and had a son before he married her, so she adopted, or at least participated in the rearing of the son. She had a more remote history of alcohol dependence, but had been sober for more than 20 years when we saw her. In terms of her family history, this is a red flag whenever we see serious psychiatric disease in the family, but her father had committed suicide at the age of 30. The circumstances of that are not clear, but it is a red flag. We could not we weren't able to extract any additional history about her father's personal history and her father's extended history, but I think that's important, and at some point I hope that we'll be able to do that. Her mother was healthy, and she was an only child. So returning to what's been happening these days, her mother says, you know, she was a sweet and kind person. She's very caring, hardworking, and in fact that's proven by how she's risen through the ranks at Arizona Charlie's. The mother felt that the problems probably began about 5 years ago. In fact, she was let go from her job at Arizona Charlie's because of increased stress. She was unable to sort of cope with the demands of the job. And she was having very strained relations with both her supervisors and with her employees. So after being let go there, she did have a lot of experience. She was able to get a job working for Walmart, where she was also a manager. And she got let go from that 2 years later for maybe sort of abusive language with certain customers. And in fact, she would use words like retard in discussing patients, discussing, it's a little Freudian slip there, in discussing customers and their problems. The mother also describes about 2 years ago that she was becoming embarrassing to the family. At her son's baseball game, she was very loud and obnoxious, and she would even swear at the umpire, to the point that the son himself felt embarrassed and didn't want her mother to come to baseball games anymore. Her mother says, her personality is completely transformed. Now, these are their words, and they're telling. Personality is something that's innate, something that doesn't change with time in a particular individual. And when a person's personality is transformed, it's often because something dire is taking place. About 2 years ago, the husband and the son were unable to maintain the relationship, and so they actually left and left her alone. She, about the same time, she totaled her car in a motor vehicle accident and was having some financial difficulties, so moved in with her mother. It's about the time when medical attention was sought 2 years ago. She saw a psychiatrist. We don't have a clear diagnosis. We don't have notes from the psychiatrist, but we believe that they talked about a depression or an unusual kind of depression. She was started on Cymbalta, which is a very powerful antidepressant, and Abilify, which is a very powerful, not a tranquilizer, but a mood stabilizer. And these two medications actually made her worse. She was seen by doctors who wondered whether there was something wrong with her brain. So she underwent an EEG and a CT scan, and these were read as normal. She also saw a therapist, and I guess when asked what was going on with the therapist, well, we played board games together. So not sure how therapeutic that was. But this is the CT scan that was taken 2 years ago in 2013. And remember, it was read as normal. I'm going to pan. So CT scan is X-ray. The white stuff is bone. The darker stuff is brain, and the black stuff is either air or water. And I'm going to pan through it to show you the scan again, which is read as normal. So as we go up from the bottom, this is the base of the skull. We can see the little hole here is the foramen magnum where the spinal cord comes out of the brain. And as we work our way up here, we'll see the cerebellum, the back of the brain, the parts responsible for balance. We see the temporal lobes over here, the places responsible for memory and language to some extent. And as we work our way up, there's not a whole lot to speak of, but some of you may have noticed as I pass through the ventricles here, this area here, that this ventricle here is a lot larger than this one. And you can also see to some extent that the gyri, and the sulci, these troughs here are a little bit wider on this side than they are on this side. So these are telltales, and of course, seeing the patient 2 years later.
The conference is about to end.
Should I just ignore that?
Yeah, not yet.
So going down a little bit more, you can tell that there's something going on here. There's a little bit less brain on this side than on this side. The patient's head is tilted a little bit in the scanner, so we sometimes see some differences that way, but there's a clear difference between this side and that side. On scans, on all radiology that we display, the right is on the left and the left is on the right. So this is the right side of her brain. So possibly, and again, we have 20/20 hindsight as a neurologist seeing the patient 2 years later, but to me this is not a normal scan. There's definitely something going on, and I think we could probably have called a little bit of frontal and insular, this part of the brain called the insula, cortical atrophy. I'm not sure why, but an MRI was done about 6 months later, and it shows basically the same thing. MRI is a lot more precise scan. It allows us to see much more of the brain. But as you can see in this case, these finger-like projections here, which should normally be really full and take up this whole space, but they're thinned out. This is called the orbital frontal cortex. Orbital because they're on top of the orbits, the eyes. So it's orbital and in the frontal cortex. And again, when we go up to areas of the brain that we're interested in terms of her personality changes, there's a lot of right-sided atrophy. And I would say maybe there's some things starting on the left too. And I'll just point out one last thing on this scan, this MRI. Here, in the polar regions, on the tip of the brain, as you can see, in the bottom here, the brain is nice and plump, but on the little areas here, we see that the brain is kind of is pulled back and shrunken, as if there were finger-like projections rather than whole fists being projected. So we call that cortical atrophy, or cortical thinning in her case. We didn't have the scan at the time. All we had were the two reports saying that the MRI and the CT scan were normal. Asking more questions of her mother, she describes her daughter as being more childlike. She behaves a little bit, and we always apologize when we mention this in clinic, but a little bit like a 2-year-old, where you ask for something and the answer is no, I don't want to do that, without any clear explanation or no ability to have a discussion about why it's no. And despite that, despite saying, no, I'm not going to do this, she's fully dependent on her mother for all her instrumental activities of daily living. Instrumental activities of daily living are those things that we need to do to stay afloat, paying the bills, taking our medications, cooking our food. So completely dependent on her mom for these things now. She wasn't paying her bills. In fact, it's something that her mother had to take over. And when asked, why aren't you paying your bills? Is it because you can't anymore? It was more, I don't really care. Bills are not important. You don't have to pay those things. She'd also lost her sense of humor. She no longer laughed at what you and I would laugh at if we heard a joke. And she also lost her empathy. The only time she would laugh, in fact, was when her mother tripped or fell or hurt herself. Then she would laugh. She would think that was funny. She also had a strange behavior where she refused to flush the toilet and would leave the bathroom in a sad state and leave her mother to clean that up. Again, without a clear explanation or a desire to understand why that's not a good thing to do. Other changes that were noted by her mom, she tended to stuff food in her mouth as quickly as she could grab it. This led to at least one instance of choking that required calling 911. And there had been other dietary changes, including a sweet tooth that she had not had previously. Her mother, in fact, had to get rid of all sweets within the house because she just raided the refrigerator and the cupboards and had put on a lot of weight as a consequence of this. Her day-to-day was mostly spent staring out the window. So she would not have very much initiative, wouldn't stand to do things, wouldn't contribute to the household activities, but would just stand and stare. Her mother had tried to get some help. She had like Social Security and disability, but had run into some barriers. I guess maybe not having a diagnosis, not having a clear explanation for why she wasn't working anymore. So there was no help to be found there for her at that time. When we saw her in March, she was overweight. The patient was overweight, but otherwise healthy looking. She appeared her stated age, maybe actually a little bit younger. She had a blank stare on her face, didn't really interact, didn't make very good eye contact. She had minimal facial expression. She had no spontaneous speech. If you didn't ask her anything, if you didn't speak to her, she didn't think it necessary to make small talk, as it were. Unless she's addressed. And then she would answer your questions, but usually in a minimal fashion. She would answer yes or no, or use the minimal amount of words necessary to answer your question, usually in an unsatisfactory way. We call that paucity of speech. It's actually a term for that context, for that kind of problem. During the examination, she participated intermittently. She would need encouragement to do any of the tests themselves, and sometimes would just stop in the middle for no clear explanation. When not engaged, she would stand and walk to the window and stare. So if we were engaged with her and then we were turn to her mother, she would stand up and walk to the window without any clear explanation. The neurological exam was fairly normal. Reflexes were a little bit brisk, and she had a little bit of what we call rigidity. But on the cognitive testing, this is the MOCA, which is the test that we do most frequently in our clinic, 6 out of 30. That's not very good. In fact, you would think this is a score. It's almost, you kind of have to try to do that badly, 6 out of 30 on this kind of test. It suggests a very advanced dementia. But in her case, I think there's some other lessons that can be learned, and she's probably not that bad. In fact, I think what we noticed during the testing is that she puts very poor effort in, and it's not really clear that she's trying even when she is performing the task. Throughout testing, she was very distracted and generally did not tend to remain on task. So this is the MOCA, just to show you some of the things that we see in the MOCA. So this is the Trails B. The task here is to go from 1 to A, 2 to B, 3 to C, and so on. So it's an alternating task where we have to keep track of, I have to follow the sequence of numbers and the sequence of letters, and I have to alternate back and forth. So it requires you to use your frontal lobes to juggle those 3 pieces of information: numbers in sequence, letters in sequence, and alternate between them. And so she did very poorly at that. This is the cube. So what you're seeing here is actually the tracing of the cube itself, the stimulus, and her drawing of the cube. She was asked to draw the cube below here, but she actually simply traced it. So she was drawn to the cube as she was trying to trace it. As she was trying to copy it, she actually just moved the pen over to the cube and copied the cube onto itself. This is her clock. When she was asked to put the numbers in, nothing came out, not able to do it. And our nurse wrote a few things here, that the patient was looking out the window throughout most of the testing. The instructions had to be repeated several times. Although when you showed her a picture of a lion, a rhinoceros, or a camel, comes out with the answer right away. So not difficult for her to identify these animals. During the testing of memory, when we test memory, we ask patients to memorize 5 words. We repeat the words, so we do this process twice. Face, velvet, church, daisy, red. So what were the 5 words? I heard somebody say face, velvet, church, daisy, red. So it's fairly easy to simply repeat the 5 words. Just sat there and nodded, not engaged in the process at all. And did that on both trials. So it wouldn't be surprising later on when we asked her, so what were those 5 words? She didn't remember any of them, not at all. She never memorized them to begin with. So we could say that her memory isn't very good, but I would say it's not her memory, it's her attention. She's not paying attention, and she's not actually doing the task. So we can't measure her memory. So on tests of attention, can you repeat 5 numbers? 218454, 21854. Can't do that. Can you repeat 3 numbers backwards? 742, 247. Can't do that either. Here we ask the patient to slap on her knee every time she hears the letter A. Just sat there and didn't do anything. Was completely inattentive to the task. Couldn't do 100 minus 7. Couldn't repeat sentences. So there isn't that interaction that you expect, that you want to have with your patient in order to evaluate them. So we can't evaluate her cognition. She's not participating. I like to throw in pictures of George Clooney whenever I can. How many of you did not recognize him? If you dare raise your hand. She didn't recognize George. She didn't know who he was. In fact, she wasn't sure who the African-American gentleman beside him was either. She had no trouble identifying the rhinoceros, but these people, she couldn't. She didn't know who these people were. With giving her a lot more information, she ultimately determined that this was the president, for those of you who hadn't recognized him yet. These are Ekman faces. Has anyone here seen the show Lie to Me? Lie to Me. It's actually a series about a guy, about this gentleman who created these images, Ekman. What the images show is emotion. So if you look to the right completely, fairly neutral emotions. If you look to the left completely, neutral emotions. In the middle, possibly scared or surprised, and in the second to last towards the left, maybe some disgust, and the last one on the right, maybe surprise or even fear. So she is completely unable to identify these emotions. She can't put a label, and she can't describe what the person might be feeling. We ordered, the only test we ordered was a PET scan. And I'll show you what the PET scan is. A test where we inject radioactive sugar in the blood. It's picked up by all organs in the body, including the brain, and it gets trapped in the organs, in particular the brain, the organs that use the sugar. So if the brain is using sugar, the radioactive sugar that we injected gets picked up by the brain, and we can see it. We can see which parts of the brain are using it. So it's actually a test that shows us brain metabolism, or brain activity, if you will. So showing you this one. Now I think what you'll see, what we see, and I'll show you. Maybe I'll go to the bottom. So this is the part of the brain where you can see the frontal lobes up here, and the occipital lobes here, the back of the brain. Normally, the entire brain should be red like this. This red is very high activity, and green and blue are very low activity. So all of you can tell that she has hypometabolism, or reduced metabolism, in the frontal areas, and that it's fairly severe. So we call this frontal hypometabolism. And she also has some in the temporal lobes. We're going up this is the top of the brain, so you can see it is also very, very significant there. And in the temporal lobes here on both sides, she also has reduced metabolism. So given what I've told you, the diagnosis is fairly simple at this point. She has bilateral, right greater than left, frontal temporal hypometabolism. That means that her frontal and temporal lobes are not working very well. And clinically, she has all of the criteria necessary to make the diagnosis of frontotemporal dementia. She's disinhibited. She has changes in her eating habits. She has these repetitive behaviors where she stands up and looks out the window constantly all day. And she has no empathy. She doesn't care for anybody else's problems. So the diagnosis is determined on these 4 clinical signs, plus the presence of atrophy and hypometabolism on the imaging. So that's how we diagnose frontotemporal dementia. The term that we tend to use now, though, is frontotemporal degeneration. We prefer that term to dementia for many reasons, and unfortunately, I frequently slip back and say dementia, but the proper term is frontotemporal degeneration. It's the term that's promoted by the Association for Frontotemporal Degenerations, which I'll talk about in a few minutes. The disease is also sometimes called Pick's disease, and I'll talk about that in a few minutes. There's no treatment for this disorder, unfortunately. The medications that tend to work the best are SSRIs, selective serotonin reuptake inhibitors, so-called antidepressants, medications that increase the amount of serotonin in the brain. She had been on one, Abilify, which did not help her. So we tried another. We tried Lexapro, which didn't help her very much either. Where I think more help was needed is in helping the mother find ways to help her daughter. So we got social services involved. Samuel, our social worker, was very active in trying to help, and we tried to see if we could get her on disability and get her on Medicare. Since she was seen, so we're talking about maybe 6 months or so, she's become more and more dependent on her mom. She needs help for dressing and showering. She stares out the window all day. She has no emotional expression or engagement in what's happening around her. When her son and her ex-husband come to visit, doesn't really matter, doesn't really care. She continues to laugh when her mother's in pain or unable to do something in particular, when her mother's frustrated by something. And her mother, in fact, is very exhausted, taking care of somebody who needs so much attention, yet who's an adult. Disability was finally obtained, and I spoke to her mom late last week, and she told me that, in fact, she had been moved to a nursing home. So this is something that if you go to the AFTD website, I found this quote and I love it. Although we're talking about our patient is a woman, we frequently see, in fact, frontotemporal dementia occurs a little bit more frequently in men. And this is a nice quote to sort of put things in context. His wife said he's having a midlife crisis. His therapist said he was depressed. His doctor said maybe it's Alzheimer's disease, but nobody said it was FTD. So that's what we're going to talk about, frontotemporal dementia. The Association for Frontotemporal Degeneration, in fact, promotes frontotemporal dementia, tries to increase our awareness of the disease. One of the quotes that I've heard recently is, FTD is the most common disease no one's ever heard of. This week, in fact, is World FTD Awareness Week, and that's in part why I'm speaking today, to try and increase awareness of the disease. And one of the efforts that the AFTD has put forward on this week of World FTD Awareness is the concept of food for thought. This is kind of a grassroots effort where people sort of get together in the community somewhere. Either last year we actually participated as well, and we had a dinner in our lunch in our event center. For those of you who came hoping that they would get the same lunch today, I'm sorry. Come together in the community to try and promote knowledge of the disease and also funding to some extent if we can. And I see Nancy Trail is here, who has organized, in fact, a food for thought for our community at BJ's, any of the 3 BJ restaurants in the city on October 8th, that's tomorrow. If you go between 11 a.m. and 11 p.m. and eat some good food, a good section of the proceeds will be donated to the AFTD. In order to take advantage of this, you need to have one of the vouchers, and I think this is a shameless publicity, but we have some of the vouchers here, so if you're interested in participating in that, please grab the vouchers on your way out. Make sure you grab the one that's of the BJ's nearest you. Is that adequate? So let me talk about FTD. I'll be talking a little bit about what it is, the different subtypes. The subtype that we just saw in our patient is what we call the behavioral subtype. But there are other subtypes. There's a language subtype and the movement disorders subtype, and I'll mention a few words about those later. We'll talk a little bit about what causes it, how it's diagnosed, although you're experts in that now, how it's treated, what the future looks like in terms of treatment, and what are we doing about FTD here. So I mentioned that FTD was sometimes called Pick's disease. That's because Arnold Pick, who was a Hungarian neurologist, published a series of maybe 6 cases at the turn of the last century where he described patients with behavioral and language changes and would fit very well the bill, are very similar to the patient that I presented today. He didn't really, I think, I don't recall what term he actually used to describe the cases, other than simply saying that there was a dementia and that there were behavioral and language changes. The term Pick, in fact, was added to the disease. The diagnosis of Pick's disease could be made after many of his students started calling the disease Pick's disease. So the term FTD or Pick's disease is a clinical term, and it's used to describe the progressive focal atrophy of the brain that begins in certain areas of the brain. I'll show you what those are in a few minutes, but the main 3 areas where the disease begins is the orbital mesial frontal, the insular cortex, and the anterior temporal lobes. Pick himself, in fact, didn't have the benefit of microscopy. He had no way of looking at the cells. The microscopes existed, but we had no really way of knowing what was going on with the cells until Alzheimer's came along in about a decade later and invented the silver stain, which allowed us to see the changes that take place in the cells themselves. And it's Alzheimer's who described the pathologic changes that occur in Pick's disease. So this is a brain. My supervisor, when I was doing my fellowship, liked to say the frontal lobes are a really big place. The frontal lobes are the blue part of the brain here. The green part is the temporal lobes. The yellow part is the parietal lobes, and the red part is the occipital lobe. So the frontal lobe is by far the largest region of the brain, and it's the part that makes us who we are. It's the part that controls our personality, our judgment, our focus, our attention, concentration. That all comes from the frontal lobes. If you will, imagine if we were able to take away all of these lobes. This is the left side of the brain that we're seeing. If we were able to take away all of that cortex and look inside in the middle of the brain, so the middle of the brain is the mesial part of the brain, we can see these areas. So the insular cortex here is here. It's a small part of cortex that's hidden behind these three lobes here where the junction is. Other areas are the orbital frontal cortex just above the eyes, the frontal polar cortex, the cingulate cortex here, and the temporal polar cortex. So these areas are the areas where the disease begins, and the areas which, when these areas are damaged, the areas that leads to the symptoms that we see. So frontotemporal dementia is actually a family of disorders. It depends a little bit on where the disease began. The changes that we can expect, as I mentioned earlier, are personality, language, or movement. Often as the disease progresses, we can get changes in more of these domains, more than one. And typically, as was the case in our patient, they occur in the 50s and 60s. In fact, they peak at around 60. We typically describe our cases in three different ways. We can talk about the clinical presentation, what the disease looks like in the clinic, how the patient behaves, what the issues are socially with the patient, what are the behaviors that we're seeing. We can describe the disease anatomically, so which parts of the brain are involved, right frontal, left frontal, temporal involvement or not. And finally, we haven't talked about this very much yet, but we can talk about pathologically. What do the brain cells look like if we were able to look at them under the microscope? And in fact, that's what Alzheimer did ultimately for Pick. Now, I like to think of all dementias, all these neurodegenerative disorders, as starting at some place in the brain and then progressing over time. The different diseases that we deal with here, these are some of them, frontotemporal dementia being one that we're talking about today, but Lewy body disease, Huntington's disease, Alzheimer's disease, Parkinson's disease are all diseases that lead to neurodegeneration. And all of these diseases have a particular protein, an abnormal protein that accumulates in one part of the brain initially, starts in that part of the brain, and then a bit like an infection, it progresses to involve other parts of the brain. So you can imagine that the very first symptoms that we might see would be related to where that first infection took place. And then, although it's not an infection, it's an inherent dysfunction of the brain cells themselves. The symptoms are due to which part are caused by which particular part of the brain is involved, and then as the disease progresses and involves other parts of the brain, the changes that will occur are a consequence of which other regions get involved. And this is an example of where Alzheimer's disease begins. Alzheimer's disease begins in the memory centers. So what's the main symptom that we see in early Alzheimer's disease? Memory loss. I don't know if this works. This is how Alzheimer's disease progresses throughout the brain. Kind of nice what you can do with PowerPoint, isn't it? This is the brain of a normal person who died of a disease unrelated to the brain. A normal brain is about 3 pounds. In fact, there was another, I don't watch that much TV, but there was another TV show called 3 Pounds, and it was about a neurosurgeon. a normal brain weighs about 3 pounds. And as you can see, and as I mentioned earlier, there's no regions where there are finger-like projections. Everything is nice and plump and the whole brain is filled in. In Alzheimer's disease, there's diffuse, especially as the disease becomes more advanced, there's diffuse loss of the gray matter and the brain shrinks. A brain of a patient with a very advanced Alzheimer's disease might weigh 1.5 pounds or a pound. In frontotemporal dementia, though, as the disease suggests,
whereas the brain just eats it up, or what?
kind of. I forgot to mention and I will answer your question, but I'm going to try to answer all questions at the end. I'll certainly remember to answer your question, but try to remember. And if any of you have other questions, please write them down or tell your neighbor, and I will address them. But in a patient with frontotemporal dementia, the disease is much more focal. In fact, frontotemporal dementia is considered a focal dementia. And as you can see from this, it's as if somebody had taken a spoon and scooped out the front part of the brain. The rest is intact. Now, I mentioned that different parts of the brain are responsible for different functions. So the left part, and in this picture, unlike the radiology picture that I showed you earlier, the right is on the right and the left is on the left. So this is normal anatomical presentation. So as you can see on this picture, this represents what the different parts of the brain are responsible for. The left frontal lobe is responsible for speech output, for what I'm doing right now. I'm exerting my frontal lobes, and particularly my left frontal lobe right now. The right frontal lobe is actually very critical for social skills. So the ability to realize what the person needs, how you're supposed to respond, small talk when small talk is necessary, shutting up when shutting up is necessary. The temporal lobes, you can't see them from this picture, but they're underneath. The temporal lobes are responsible for memory. The right temporal lobes more so visual memory. The left temporal lobes verbal memory. The parietal lobes in the back are responsible for reading and arithmetic and visual spatial organization, understanding our visual environment. And the occipital lobe is where we process vision. So to put the different frontotemporal degeneration disorders in context, the behavioral variant, as you might gather from the picture I just showed you, results from involvement of the right frontal lobe most of the time, sometimes the right temporal lobe. I mentioned that the left frontal lobe and temporal lobes were involved in language. So if the disease begins there, the problem won't be a behavioral problem, it'll be a language problem. The person will have difficulty expressing themselves and might have a lot of trouble understanding what people are saying. And there are two forms of this. If the disease starts in the frontal lobe, we have a disease called progressive non-fluent aphasia. If it begins in the temporal lobe, we have another disease called semantic dementia. And they're very different, very interesting diseases. But ultimately, as the disease progresses, they coalesce into one disease with many of the features of all of the diseases mixed together. A little bit more about the frontal lobes then. This is being repetitive, certainly, since you see that it comes back to the patient that we talked about earlier. Somebody with frontal lobe damage will act inappropriately in social contexts, could be apathetic, will have lack of interest in other people's feelings, will lose what we call interpersonal warmth. They might be repetitive and have compulsive behaviors. They'll have changes in their food preferences. They might have executive dysfunction, so that's the ability to sort of do more than one thing at once. And they could develop language dysfunction as well. And frequently these patients have no insight. They're unable to understand what's happening to them or to appreciate that there's actually something wrong. Here is a video of a patient. I've shown this before. I don't know if any of you have seen it, but I think he's going to show us. He's going to tell us the months of the year in reverse. So you can try that yourself. December, November, October, September, August, July, and you should be able to do that fairly quickly in about 10 to 15 seconds. Watch how long it takes him, but also watch his behavior during the process.
Could you say the months of the year, but say them in backwards order? Start with December
Oh,
and go back to
December,
January.
Yeah. December, November, October, September, August, July, June, July, June, May, April, February, January.
So it's actually kind of fun to be with. He's an entertaining character. But he's demonstrating a couple of things. He's demonstrating, one, that it's hard for him to do that task. It took him a full 25, 30 seconds to do it. He had to restart a couple of times during the process. He's also giggling and laughing in a kind of inappropriate way with the examiner. The examiner is a very famous neurologist at the Mayo Clinic. And this is a video that they made available to us through a copyrighted program called MedLink. So I have to give credit to that. But it illustrates really well this kind of strange, uncaring behavior about the situation. And finally, he's moving his hands back and forth, and he's clapping on his tummy and clapping on his legs. So these are stereotypies. This is these kind of repetitive movements that we sometimes see. I have two movies. The second one's coming up now. This one is actually a témoignage. Is a woman who tells us about her husband and his behavior. It's a video loop that comes from a movie that was put together by UCSF, the University of California in San Francisco, where probably one of the institutions that's contributed most to our understanding of frontotemporal dementia. So listen to her story about how her husband behaved with their daughter.
He pulled my daughter, who wasn't wearing a life jacket and didn't have her inner tube. He took a stick and they were playing a game, and he pulled her out into the deep part of the river where the current was fast, and then he dropped the stick and swam away.
So we're all struck, and we're all, what? Who would do that? Somebody with frontotemporal dementia, or somebody who just wants to hurt people. Somebody with frontotemporal dementia doesn't want to hurt people. They just don't get it. So moving quickly, the language variants, as I mentioned, together there's two major forms, and there's a third form that we sometimes see in Alzheimer's disease, and it can also occur in FTD, called the two forms that I've already told you about are the non-fluent aphasia and the semantic dementia. And there's another form called logopenic progressive aphasia. We group all of these three aphasias into the concept of primary progressive aphasia, and separating them out clinically can be a little bit difficult at times. And again, what determines which one we have is led by which part of the brain is involved at first. All of these cases, whether it be logopenic or semantic or non-fluent, they all ultimately progress to include a behavioral component. And this kind of illustrates that. This is a slide showing the brain of people who suffered, an average of many people who suffered from primary progressive aphasia. And as you can see, in all three, a different part of the brain is involved. So the patient had 2 visits. These patients had 2 visits. Visit 1 is in green. Visit 2 is in blue. And what you can see is that there's more of the brain is involved between visit 1 and visit 2. And what you can also see is that in the case of the logopenic aphasia, it's this part of the brain that's involved initially, and then a whole bunch of other parts of the brain become involved. In the non-fluent aphasia, it's the frontal part of the brain that's involved at first, and then other parts get involved. And finally, in the semantic form, it's the temporal pole that's involved initially, and then other parts get involved. So all of these diseases start somewhere and then progress to involve other parts of the brain. Here is a video of a very famous patient, Ann Adams, who suffered from PPA, She had difficulties with language that progressed over many years. She was studied by a number of physicians, including ultimately the group at UCSF who produced this video. The person interviewing her is Mary Lou Gorno-Tempini, who actually published the most on the concept of primary progressive aphasias more recently. And I have to say, Marcel Mesulam, who was my supervisor during my training in Chicago, coined the term primary progressive aphasia, and he's contributed the most to this literature. But the UCSF group, working with other groups, has added a lot to our understanding of these diseases. So listen to Anne describe what she sees.
And I'd like you to take a look at this picture and take your time, and please tell me what you see. And if you can, please try to speak in sentences. Okay? Take your time. I know this is a little bit difficult. Tree. People.
So it's as frustrating for everybody as it is for her. I don't know if you noticed, so she didn't talk in sentences. She pointed. She tended to point to things on the paper, and she used single words to describe a very complex scene with lots of stuff going on. I don't know if you noticed as well, she wasn't using her right arm. Her right arm was stiff right beside her on the. We can probably just show you the picture. Oh, no. You can see right away.
And I'd like you to take a look at this picture and take.
When she starts pointing, she's a right-handed person, but when she's pointing, she points only with her left hand. She's not using her right hand at all. So she had a PPA, a primary progressive aphasia, that progressed over time. Ultimately, she developed a disorder called corticobasal degeneration, which is part of the frontotemporal dementia spectrum disorders, where she developed the left side of her brain was much more involved than her right. And you can see here some of her MRIs with time, how this area of the brain which is involved becomes more and more involved, and much more than the other side. Now, Anne is interesting because she was a biologist, but at some point in time, she became very, very interested in art and started creating incredible pieces of art. And you can see some of them here. The one so her first language symptoms appeared in 2000, and the diagnosis of PPA was made in 2002. But in 1998, 4 years before that, she started developing an interest in art, and she produced the square. I'll show you this picture here, which is a graphical representation of the number pi. Yeah. Now, if you think about that, if you think about wanting to represent the number pi graphically, you think you have to be a little bit compulsive. Huh? You need to have that kind of very, very precise, very attentive, looking at something very, very attentively for a long period of time. And she developed. This is one of her first paintings. There's some others here that she drew from her experience in biology. But again, you can see beautiful, beautiful paintings, but incredible detail and obsession over the colors. This is a phenomenon that we do see in patients who suffer from frontotemporal dementia, particularly those who suffer from left-sided involvement. We have a patient here who also developed artistic tendencies as his disease progressed. He also has a movement disorder associated with his disease, and this is one of his paintings. Really, really beautiful use of colors. Again, incredible attention to some of the detail. Very beautiful. So what about the movement? Well, I mentioned corticobasal degeneration. There's another disorder called progressive supranuclear palsy, which can occur. And these diseases often co-occur with the aphasias. Sometimes motor neuron disease can also occur in patients with frontotemporal dementia. Motor neuron disease is the disease of the muscle, or the neurons that control the muscles. It's also called Lou Gehrig's disease. And as I mentioned, I haven't mentioned this before, but frontotemporal dementia can present in these many ways. And in fact, in a single family with a gene causing the disorder, you can have any one of these presentations. So it's kind of difficult. Sometimes it's difficult to get a good family history, because if we say, well, did they have behavioral problems? Did they have memory problems? Did they have movement disorder? Did they have neuromuscular disease? They all fit in the diagnosis. What causes it? This is in part an answer to your question. We don't know. We don't know what causes the disease. We know that something happens in the neurons that starts causing the accumulation of abnormal proteins. We don't think that there's an environmental cause. In fact, most cases are probably going to turn out to be genetic. We know that about 40 to 50% in some groups are genetic, that there must be a gene involved, and we can explain about 15 to 20% of those with gene mutations that we know, that we can identify. Unlike Alzheimer's disease, which has dual pathology, Alzheimer's disease has plaques and tangles. Frontotemporal dementia has only one pathology. It's a different pathology in different people, but there's always only one. So there's either tau accumulating. Let me point this out here. These are some of the proteins that we know accumulate in the cells, the abnormal cells. Abnormal tau accounts for about 40% of cases. Another protein called TDP43 accounts for about 45% of cases. So the majority of patients with frontotemporal degeneration will have one of these two, tau or TDP43. And then there's a smattering of other abnormal proteins that we can find in some cases, but they're much more unusual and rare. The genetics, as I said, is a very genetic disorder, up to 40% of cases in some studies. These are some of the genes that are involved. The gene for tau, in fact, if it's mutated, can cause accumulation of abnormal tau and the disease. There are two gene mutations that lead to TDP43 disease. These two genes are progranulin and chromosome 9, open reading frame 72 mutation. And then there's a smattering of other very rare, unusual genes that are not very frequent. But by far, these three genes together probably account for up to 80 or 90% of all of the genetic causes that we know. I won't go through this. I just put it in there. Is it in your handout? Yeah, I put it in there to sort of try to put together how these things combine, how we understand the disease itself. But as I mentioned, having a gene that causes a specific pathology can lead to different clinical presentations. So when we see the patient and we examine the clinical presentation, it's very hard for us to know what's going to be in the tissues and whether there's an actual gene involved. So the best way in the future to make the diagnosis will be to actually find the gene. So how is the disease diagnosed? Well, you saw the process a few minutes ago. The behavioral changes are normally noted first. They're often very subtle initially, things like falling down the social ladder, losing your job. Misdiagnoses are very common. And if language symptoms occur first, typically the patient is aware. But if language symptoms are not present, typically the patient is not aware, and it's the family that realizes that there's a problem. So what does the neurologist do? I didn't make this slide, so I haven't taken the time to take my picture, and I apologize for this self-publicity. But the neurologist will take a history, get a sense of what's going on. We try to speak to family members separately to allow for a sort of more open discussion about what's going on. We do initial cognitive screening, and we do a neurological examination, then we order tests. MRI is by far the most common test, and in this particular patient, she also had an FDG PET. We often order neuropsychological testing, and in some cases, and that's something that we'll be doing here in the very near future, genetic testing. This is an example of a very advanced disease where the person was asked to draw a clock. No idea of what a clock really is. Just put in all of the numbers. The different tests that we can do, the MRI, you saw what it looked like. There's atrophy of certain parts of the brain. They're usually very focal, and they're usually not the areas that are involved in Alzheimer's disease. The PET scan shows us changes that are more profound, more easily seen than in the MRI, and sometimes before they're present in the MRI. There are other types of PET scan that look at things like amyloid plaque. Amyvid is one of those types of scans. We don't do them routinely here, but if we were able to do an amyvid scan in any one of these patients, we would realize it would tell us that the patient does not suffer from Alzheimer's disease. The scan would be negative. We often do lumbar punctures also to exclude Alzheimer's disease, and as I mentioned, we do, hopefully we'll be doing genetic testing soon. Again, this is just showing you what you already know, that the atrophy involves the frontal and temporal lobes, and that the PET scan can show us the changes much more dramatically. The neuropsychological testing is very helpful in determining the pattern of deficits. As I mentioned when we went over the MOCA and why the patient was having trouble, why she did so poorly on the testing, neuropsychologists are much better able to sort of separate out, well, is this a memory problem? Is this a behavioral problem? Is this an attentional problem? The neuropsychologists will spend much more time seeing where the strengths and the weaknesses are, and the pattern that they come up with will allow us to get a better sense of what disease we're dealing with. Ultimately, when the patient comes back to see the neurologist, we frequently order more tests. We try to offer them involvement in clinical trials. There are a few in NFTD, although none of them are currently being run from here yet. And we try medications. In the patient that we just talked about, we're so sure about the diagnosis that medications that are typically used for Alzheimer's disease, like Aricept or Namenda, weren't even attempted because they've been shown not to be helpful in FTD. And that's one of the reasons why it's important that we get the diagnosis right, because the treatment is a little bit different. So in FTD, the medications that have been shown to be most helpful are the SSRIs, the antidepressants. Trazodone has the best track record right now, but medications like Lexapro, which is escitalopram, or Zoloft, sertraline, have been very helpful. They help calm the patient when there's agitation. They help reduce some of the irritability, and it makes interacting with them much more doable. As I mentioned, Alzheimer's drugs have been actually shown not to be beneficial, and in some cases actually more harmful. I'll mention here quickly, there's a new drug on the block called Nuedexta. It's a medication that was recently approved for the treatment of pseudobulbar affect. Pseudobulbar affect is when people go from being happy to being sad very, very quickly. We also call it emotional lability. It's something that we see a lot in ALS and Lou Gehrig's disease and in multiple sclerosis. The medication was recently underwent a very large trial in Alzheimer's disease for agitation, and it turned out to be a very helpful medication. Very, very good at controlling agitation in diseases other than Lou Gehrig and MS, and in patients who don't have pseudobulbar affect, and patients who just have agitation. And so we think that Nuedexta may be very helpful in our FTD patient population in helping the disinhibition and the agitation that they experience. And we're going to run a trial very soon. It's supposed to start possibly at the end of this year in all patients with disinhibition, but I think a good proportion of those patients are going to be patients with FTD. So as I mentioned, currently we treat the disease symptomatically. There are upcoming clinical trials. Social work is critical in helping manage the disease and helping the families work through what they need to do. And we're very happy here. We have Lisa Radin and Samuel Hickson who run our support group. And I get a lot of positive feedback from my patients and caregivers about that. Language support by a speech pathologist is sometimes helpful. Occupational therapy, we've just obtained, we have an occupational therapist that just started working with us recently. We're very happy to have her, and hopefully we'll be able to help fine-tune the attention she pays to patients with FTD. And physical therapy is important to keep patients active. Almost done. There are multiple new drugs that are potentially going to help. Many of these are targeting the pathologies that I described. So it'll be very important that we be able to say, oh, this is TDP-43, or oh, this is a tauopathy, and then use a drug that will act on that pathology specifically. Progranulin is one of the gene mutations that I talked about. There are efforts to help patients who have a progranulin mutation specifically. Progranulin is a hormone or a secreted substance that helps cells survive in the brain. When patients have a mutation of this gene, they have less of this particular hormone. So the new drugs try to increase the production of the hormone itself. So potentially very, very effective medication, we hope. Oxytocin, which is the hormone that's secreted by the pituitary when a mother has her baby, is a binding hormone that helps emotional binding with individuals, so the mother with her baby, for instance. There's been recent studies showing that oxytocin is very helpful in helping patients who have this inability to appreciate another person's feelings, helping in this emotional warmth. Something to look for in the future. Yeah, and I think the last thing I want to say is that in terms of diagnoses, in addition to the genetic testing, there are more and more types of PET scans. In particular, there's a new PET scan, new ligands for PET called tau ligands that allow us to detect the abnormal tau accumulations. So in half of the patients that have tau, we'll be able to know that by simply doing a scan. And we'll be able to get patients like that involved in clinical trials early. There's a lot of resources. Our library has many. I think many of them have been brought up here, down here already, so you can take a look at that. I mentioned them in the notes. There's Lisa's book, What If It's Not Alzheimer's Disease? I don't get a cut, unfortunately, every time I mention it, but I have no hesitation in recommending it for anybody who's dealing with frontotemporal dementia. And there are a lot of other books, all of these available online. You can order them, and they're free. And on that, I will close. Take questions.
Where is the library?
The library is on the ground floor here in near the radiology suite.
And the radiology suite is?
If you in the main building, in the main clinic building, when you walk in, there's a reception there, and they'll direct you to the library, but it's immediately to the left. Hi.
I was born left-handed, was forced over to the right, which I think brought on stuttering when I was very young. Is that what happens? I was the only child of 6
Yeah,
to stutter.
to stutter.
But I was the only one shifted from left to right.
Oh, I'm
It's sinister.
yeah, sinister man. There isn't a simple answer. It's not yes or no, but we do think that that your brain is wired in a certain way and ready to take on the world in a certain way. It does adapt as the world changes in front of you. And so if you're forced to adapt to the world in a way that's not natural for your brain, there could be some complications. And stuttering is certainly a very common complication. So it could certainly be.
Dr. Chair, tell me more about this young onset clinic, please.
On
page 29.
That's me. I run the clinic on Fridays. It's a time when I see patients who have memory loss or behavioral changes or aphasia. The clinic has been very generous with me in allowing me an extra half hour with patients in order to sort of get a better idea of what's going on and to assess them better.
So those appointments are scheduled ahead of time?
Yeah. And typically the clinic also involves I mean, they're not directly involved in the clinic itself, but the clinic does depend on physical therapy, occupational therapy, speech therapy, and social work. So if you want to think about the clinic, it involves these other, it's multidisciplinary, and we do have, we do work together in trying to help the patients that come through this clinic. So it's where we're trying to offer the best services possible to patients with these disorders.
Okay, thank you.
When you were discussing the case of the 54-year-old woman, and you said there was a family history of a suicide, why did you say that was a red flag?
Well, I mean, suicide is not uncommon, but frequently, as I mentioned, the disease itself can present in many different ways. And so if it presents with a strong psychiatric component, it could lead to really difficult circumstances that could ultimately lead to suicide. When I ask, I get a family history on all my patients, and rarely do I get, oh, my dad committed suicide when he was 30. I think I probably follow about 3,000 patients or so that I've seen since I've been here, and I've only heard that twice. So it is something, what? And you write it down, and then you say, well, what was it about him and his circumstance and his family? What was, why wasn't he able to cope with life other than depression? And does he have siblings? What were his parents like? I'm looking for that genetic link. Does that answer your question? Yeah.
Outside of medication, which doesn't seem to be readily available, what have you found is the most successful treatment or ability to cope?
Yeah. I think education is probably the most, and I say that tongue-in-cheek a little bit, knowing what you're dealing with and trying to learn from what's going on is really the best approach. Everybody is the frontal lobes are a really big place, and so when the frontal lobes get involved, people are going to be very different. I mentioned that the patient that we talked about acted a lot like a 2-year-old, like a toddler, just no. I'm not. And so if you learn to react to those problems in the same way that you need to learn how to deal with your 2-year-old, the stress is much less, and you can actually get things to move along in a more socially acceptable way.
About this drawing, is this an allusion to FTD forests?
No. Yeah, I'll show you another drawing, which was intended to depict FTD. But as you can see on the left is the brain and the atrophy that we see, and then on the right is a representation of it, sort of that part of the brain falling apart, but also the development of new abilities, including art.
Well, we have to laugh, otherwise we just cry all the time.
I agree. The first video that I showed you of that gentleman that was kind of funny and fun, that's laugh, and he enjoys laughing as well. But ultimately, it's very serious. And that particular gentleman passed away about 3 years after that video was done of a pneumonia in a nursing home.
Thank you. Who's the youngest person that you know that would have had it?
I can't see who's speaking?
The youngest
Oh, I'm sorry.
The youngest person.
The youngest I've seen is in their late 40s, but there's documented cases in the literature in the late 20s. Yeah.
How common is FTD compared to Alzheimer's? I know it's a different age group usually.
Well, as I mentioned, it's probably the number one. It's misdiagnosed, so I think that we don't have a really good sense of how frequent it is. I think it's estimated that the number of formal diagnoses of FTD in the U.S. right now is about 50,000. So it's not very much. It's considered a rare disease. But below the age of 65, if I'm a physician and I'm seeing a patient in my office and they're 60 and they have a memory problem, there's a 50-50 chance that it's FTD rather than AD. So it's that common.
What would one of those brain scans cost?
Which ones? Well,
Like here?
the standard scan that we do, the MRI scan, can vary depending on where you get it done and how complex the sequences are, but anything from a couple of $100 to $5,000 if it's a very complex scan. The PET scan itself, the PET scan, the one where we inject the radioactive sugar, that's about $3,000 to $5,000. They're all covered by Medicare, and in fact, the MRIs are always. I've never had trouble getting an MRI from a third-party payer, insurance companies. The PET scan is sometimes a little bit difficult with third-party payers, but we often are able to convince them that it's the right test to do for the reasons that you saw today. Lisa, I think you were next.
I just want to mention, I facilitate the support group here, and I just want to mention when someone asked about the age, I do have someone who is a family member who's diagnosed in her early 20s.
Early 20s.
Early 20s, yeah, with PTSD. So it runs the
Gamut, yeah. And there are cases in the late 80s as well, so it can really be that different.
But I'd just like to mention that if anyone is, someone asked about sort of coping with the disease, that the support group is a wonderful place to feel comfortable, be able to say whatever needs to be said, however you feel. It's really a safe place for people to come and be able to be supported.
I apologize, Lisa, for missing the cue there. I should have mentioned you there as well. And I agree fully. We refer people to Lisa's support group every time from the first visit and every visit after that. And I highly recommend it.
Are there any studies about FTD and diet?
The simple answer is no. No. As I mentioned, the diseases it's a disease we think that is inherent, probably it has a strong genetic base, and even in the people who are sporadic or where there's clearly no family history, I think that we're going to find that there's a combination of genes in these patients which are causing the disease. Unlike Alzheimer's disease and Parkinson's disease, where the environment and the diet have a lot to do with if and when you develop the disease.
Are there any current gene treatments?
No. No, only the progranulin that I talked about, and it's not actually gene treatment, but it's a way of making what's the gene there work harder.
Is there a difference between the progression of Alzheimer's disease between an early onset patient and a patient over 65?
So the question, if I may repeat it,
Yes.
is there, if we just talk about Alzheimer's disease, so young onset disease, so sometimes it's not clear whether it's Alzheimer's or FTD, but I'll say that when we see patients with Alzheimer's disease that present before they're 65, and if we compare them to people who present when they're in their 70s, it is a very different disease. It's a different disease in terms of there's only the Alzheimer's disease that's present. There isn't vascular disease, there isn't a sleep disorder, there isn't all these other things that make the disease worse. And so it's a more pure disease, and the disease tends to affect other functions in the brain, the frontal lobes and the language centers more. So from the get-go, it's a different disease. When it occurs in younger people, it shows. We can see that the disease is there. It's often been present for a while already, and the patients have been compensating for the disease for so long, so that when we see them, they're actually more advanced. And so the disease seems to progress much more quickly after we make the diagnosis. So I think that answers your question. In younger patients, the disease tends to appear more aggressive.
Yeah, it does somewhat, because I've done a lot of reading on this in regards to early onset Alzheimer's. And one of the comments is that quite often the family member does not take the patient until it's much more pronounced, and there's a wait time between 5 years to 10 years, whereas if they were taken earlier, perhaps after the diagnosis, a treatment plan, and I clearly understand that there's no cure for this, but then perhaps other people could become involved to help the patient.
Right.
10 years ago, there wasn't really much anywhere to go.
This is true. We still don't have, we have not been able to show by any means that we can slow down this disease. We're just starting to get a signal in Alzheimer's disease. We're just starting to get a signal with some of the new antibody treatments, the immune treatments of solanezumab and aducanumab, these two new antibodies that block the accumulation of amyloid plaques. So your question of, well, the sooner you can get the treatment going, the better you're going to be off. Yes, absolutely. And because we're just starting to have these new medications, we are working really hard at making the diagnosis as early as possible. And that's where the scanning, the types of scans that I talked about are important. And that's where patients who have a genetic disease is also very important, because if you have the gene, you're going to get the disease. And so those are the perfect people to treat as early as possible. But you're right, though, just knowing what's ahead and sort of creating a social structure around the disease, around the patient, and helping the family and the patient through the process, it can go it can go a really long distance. It can really help, because when you fall through the cracks, the disease, the stress of that situation, the poor health that you're likely to experience because you're falling through the cracks is going to make the disease worse. And so we can actually help that way.